Okay, so we'll be talking about essentials of transcatheter embolization. This talk is aimed at basic and or intermediate knowledge. So basically what the talk is aimed at is either interventional radiologists who want to refresh their memory a little bit. They may know many things that are in the lecture, but hopefully pick up some nice bits and pieces here and there. It is hopefully also useful for diagnostic radiologists because it gives some more insight into what interventional radiologists are doing and how imaging period procedural around embolization procedures can be helpful in doing an embolization procedure, and furthermore, it may actually give some more insight into why interventional radiologists do things the way they actually do them. And last but not least, I'm hoping there are some young residents or young radiologists in the audience who will see this lecture and think, well, that's a cool trade. I want to be in interventional radiology too, and maybe persuade them to go into a career as an interventional radiologist. So having said all that, these are the learning objectives that you could find in the syllabus. To understand the basic concept and indications for embolization, there are a whole lot of different indications for embolization, and it's probably 1 hour is not enough to discuss all of them. Moreover, I think 1 hour would even be enough to discuss only one of them. So what we have to look for is some of the basic concepts and basic principles that apply to all kinds of different types of procedures that you use during embolization. And there are some features that are shared by all types of embolization, so we can try and look for these. Furthermore, we'd like to learn a little bit about the practical aspects of embolization, the techniques of endovascular navigation, and the site and the way we deploy different types of embolization products. And finally, we hope to learn a little bit about the results and complications of embolization. And again here, it's very difficult to make a general remark about the result of embolization because the aim, the clinical aim of embolization will have a lot of variation throughout different patient populations. So it's very hard to make a statement on results of embolization in general. However, complications do share a lot of common features, so we will be able to discuss some of these and hopefully find out how imaging can help to detect a couple of these. So this is the outline of the lecture. We'll first take a look at the aim of embolization. We'll then try and figure out some variables, clinical and imaging variables that may influence the way you approach an embolization and the technique you use when you're doing an embolization. We'll go through the different procedural steps of an embolization procedure. We'll look at the basic types of embolic agents. There are many different, but they can easily be categorized in different broad categories, and we will not discuss all of them. We probably will stick only to those that are most frequently used in everyday practice and that you as a diagnostic radiologist are likely to come across when you're reading films or doing procedures. As said before, we'll take a look at complication results, and hopefully there's time to leave you with some take-home messages. So to start off, what actually is the aim of embolization? Well, I guess I've described the aim of embolization here in a very technical way, and probably is not the correct way because the aim of embolization is not occluding vessels. The aim is obtaining a clinical result, and this clinical result is very different in different patients. So if we want to make it into something that's generally applicable, we should probably say the aim is to occlude vessels of choice as selectively, safely, and effectively as possible. And I specifically say selectively, safely, and effectively as possible because these are different aims, and sometimes the different aims are in conflict with each other. So that's why the second sentence says, clinical circumstances may lead to a trade-off between selectivity and speed. So when you want to do something very selective, meaning only occluding the vessel of choice, this may sometimes take a long time, and in some situations you don't have that time. So then you have to sacrifice a little bit of selectivity to gain some speed. Or another example, sometimes if you're very, very selective, you only occlude the vessel of choice, you may not occlude some other vessels that are likely to be collaterals. So you're very selective, but you'll have a rebleed, so you lose some effectivity there. And of course, the more vessels you occlude, the less safe a procedure can become as you'll increase the chance for inducing ischemia of the end organ. So these different variables are in constant conflict with each other, and it's, as a good clinician, it's your task to find a sort of optimal trade-off between these different factors affecting the outcome of your procedure. And as I said before, as I started off with, the clinical result is more important than the imaging result. So very often, after an embolization procedure, we do no follow-up imaging because it, at that particular moment, has no clinical consequences for the patient. If the patient's doing well, if the patient has no complaints, if the patient's no longer bleeding, if the patient's hemoglobin stays normal and doesn't decrease, there very often is no indication follow-up imaging. However, we would like to do it sometimes because it's nice to look at a pretty image. So what then are the variables influencing the embolization technique? There's many variables, but I've tried to categorize them in these three categories. First of all, the type of vascular territory that's involved in the procedure. And we'll look at some more detail at the different types of vascular territory in the next slide. Secondly, the clinical setting. I've already explained that sometimes speed and selectivity are in conflict with each other. So the situation of the patient, the clinical situation, dictates really the way you do a procedure. And of course, very important is the type of underlying disease to be treated. And we will in one of the next slides also look at different types of underlying disease, because different types of underlying disease may very much influence the way you approach the procedure. And some types of underlying disease are much harder and much more difficult and much more dangerous to treat than some other types of underlying disease. So what then are the different types of vascular territories to look at? Well, first of all, of course, you have arteries and veins. What are some basic differences in terms of embolization? Veins are often larger than arteries that you're trying to occlude. So the type of embolic agent you use or the type of coil you use is often larger for veins. Also, veins are more flexible. So the diameter of a vein can vary considerably. Now, the normal diameter of an artery doesn't change that much. So suppose you have a 5 millimeter artery. Usually in everyday life, the diameter of a 5 millimeter artery will vary probably somewhere between 4 and 6 millimeters. But a vein, suppose you have an 8 millimeter vein, the diameter of the vein can go up to 10 or 12 millimeters. So you have to take this into account when you're doing a procedure. So you use different materials or different size materials when you're using arteries or veins. Also, what you have to realize, when you deploy an embolization product in an artery, and it's a wrong size, it'll go completely the opposite way as in a vein. It'll go downstream. So if you, for instance, put in a small coil in an artery, it'll go downstream either in a leg or a liver. It's going to go downstream to the target organ. On the other hand, if you deploy something in a vein that's too small, it's going to go centrally to the heart. So it's going to go back to the heart. It can stay in the heart. It can lodge in the lungs. If the patient has a patent foraminal valley, it may actually end up in the brain. So although venous embolization appears easier than arterial embolization in everyday practice, when you lose embolization products in a vein, the consequences could be much more dangerous than in an artery. So the way embolization products go is completely on opposite ways. So the consequences can be completely different. Then there are small and large vessels. Small vessels are easy because small vessels are easy to occlude. You just put in a limited number of particles or a limited amount of coils and they're occluded. Large vessels, much more work. Also for large vessels, sometimes you need bigger deployment catheters or sheaths. Because if you want to put in a coil that's, for instance, 20 millimeters in diameter, you have to put in a bigger guiding catheter, a bigger catheter for deployment, so then you have to change the equipment you use, and sometimes it's difficult to put in very big equipment with large diameter. Smaller vessels can be difficult to negotiate because large vessels are easy to negotiate. You could put in a regular 5 French catheter sometimes. In small vessels you have to work with micro catheters, are much more difficult to negotiate. Also, if you're using catheters in large vessels, they're often rigid and stiff. So they're very stable. When you're using catheters in small vessels, often they're very thin, they're very flexible, and their position is often very unstable, and we'll come to that a little later also. Disease process is very important, and we'll come back to the disease process in the next slide or so. The target organ is important because some target organs are much less sensitive to ischemia than other organs. Also, when you actually induce ischemia, the clinical consequences are much less severe in some organs than other organs. So, for instance, the brain, of course, it's very dangerous. But if you, for instance, infarct a portion of the spleen or the kidney, this can occur without any clinical consequences. So the consequences of something going wrong in different organs is for the patient completely different. And then there's different kinds of arteries. There's a so-called end artery. There's arteries that are often referred to as transport or transportation arteries. And there's arteries with less or more collateral potential. And I'll show you some some examples of this kind of vessels in some of these schematic drawings in the next couple of slides. If you look at this slide here, you see here the vascularization of the duodenum, which is over here, and the pancreatic head and the body of the pancreas. And here you see the vascularization of the stomach. And you see there's lots of arteries going into the organ, but also vessels coming from the other side. So for instance, from the celiac axis here, there's vessels going into the pancreatic head, supplying the duodenum, but also vessels here going into the pancreatic head, supplying the duodenum from the superior mesenteric artery. So suppose you occlude this vessel here at this side, this branch coming off the off the hepatic artery, the gastroduodenal artery. Chances are the flow will reverse and the bleeding will go on because there's a lot of collateral blood flow coming from this side. And the same goes for the stomach. The stomach is basically supplied by arterial arcades rather than end arteries. So if you look at the gastroepiploic arteries, the right and the left one, and the right gastric artery and left gastric artery here coming off the celiac axis, you can see if you include this one, or that one, or that one, or that one, there's going to be a lot of reversal of flow and a lot of collateral supply coming from the other side, which is on the one hand safe because it's very difficult to induce ischemia to the stomach or the duodenum or the pancreatic head. But on the other hand, there's a good chance the bleeding will go on or the bleeding will recur quickly. In the kidney, which is an example of an organ that has end arteries, the situation is much different. You can see that these branches here are going off to different segments of the kidneys, and you see there's not a lot of collateral supply potential of these arteries going to the other portions of the kidney. So if you occlude this vessel here, for instance, for a bleed or a tumor here, there's a good chance that the bleeding will stop because there's not enough collateral potential to supply the bleeding area and to maintain the bleeding. On the other hand, when you occlude this vessel, it is much more likely to cause ischemia. So what will probably happen is you'll infarct this portion of the kidney when you embolize it. So everything comes at a price. Either you're very effective and you cause some ischemia, or you do not cause ischemia, but there's a higher chance for rebleed and you're not so effective. And that's what I meant with the trade-off between these different properties of vessels. So let's look at the clinical setting. If you're planning a procedure in a patient who is in a good clinical condition and you can do an elective procedure, it gives you time to plan a procedure, it gives you time to make a planning CT or a planning MRA or what have you, and this will facilitate the procedure. If you have time to do this, you can do a CT scan, you know where you're going, and that will save on contrast and will allow you to order the right materials or to install the right materials before you start your procedure. On the other hand, quite often you have emergency procedures, for instance, in patients who are bleeding from the bowel, either the upper GI tract or the lower GI tract, or maybe patients who are bleeding from the lungs, from the bronchial artery system, or patients who are bleeding from the pelvis, a ruptured spleen, a ruptured liver, or a ruptured kidney in trauma cases, and here you don't have time to plan your procedures. You have to go in and do the procedure. So you don't have time to fiddle around and think about the procedure, and you have to make decisions. And sometimes this goes at the cost of selectivity. But again, if you save a patient's life by being a little bit less selective and sacrifice a little piece of kidney or a little piece of spleen, that's okay. Another clinical setting that often influences your embolization is coagulation. If the patient has a poor coagulation status, this will influence your procedure because some of the regularly used embolization materials rely on the coagulation of the properties of the patient itself. For instance, if you use coils, coils basically work on the basis of coagulation. So if the patient has a really poor clotting status, probably coils will not work and you have to change your strategy and use something else. So to summarize all this, it's always a matter of weighing risk and benefit in every patient. And it's much easier sometimes in elective patients where you can plan everything, and it can be more difficult in emergency procedures where you have to make a quick choice and decide. Sometimes the decision is wrong, but that's what happens when you don't have much time. So what about underlying disease? There's many kinds of underlying vascular disease that may cause somebody to bleed or somebody to require an embolization. Probably one of the more clear and easier ones is hemorrhage, and particularly, for instance, hemorrhage in the setting of trauma or an ulcer in the stomach, because there you have a nice focal bleeder. And at the end, I'll give you my paradigm of focal versus diffuse disease, because generally speaking, focal disease is much more easy to treat than diffuse disease. So any diseased process or type of disease that is a very diffusing character is more difficult to treat and more dangerous to treat than something that's very focal. And particularly in trauma, when there's one nice focal bleeder, that's usually quite easy to treat. On the other hand, if the patient has a tumor that has lots of pathological vessels coming off different branches feeding it, or if the patient has an inflammation of the bowel and a longer trajectory of the bowel is involved, it's of course very difficult to treat all this without sacrificing and inducing ischemia of the bowel. So focal versus diffuse for all kinds of different embolization procedures is a very important principle. Then you have aneurysms and false aneurysms. Now these are mentioned in one line, but they're basically quite different. An aneurysm is just a focal dilatation of the wall. So if you have a normal wall with intact layers, and if you actually exclude the aneurysm from the circulation, then you've treated the aneurysm. Now, a false aneurysm is something different, and it's basically nothing like an aneurysm, because a false aneurysm is basically a hole in the wall of the vessel. So it's either a hole throughout all the layers of the vessels, including the adventitia, or it's an almost complete hole with only the adventitia standing. So that's an essential difference, because the way you treat is also very much different. Suppose you want to treat a false aneurysm and you put your coils or embolization material into the false aneurysm. What you're basically doing is pushing your coils out of the vessel into a hole that's outside the vessel. So this will often not be a permanent treatment. So what you have to do in the case of a false aneurysm is actually occlude the vessel that feeds the false aneurysm and not treat the false aneurysm itself, because, as I said before, it's basically not an aneurysm, it's just a hole, a focal hole in the wall of a vessel. AVMs and AVFs, so arteriovenous malformations and arteriovenous fistula, are very complicated, should probably in most cases only be treated in expert centers by expert operators, so it's best to probably leave them out of this basic to intermediate lecture. Tumors could be either benign or malignant, and tumors could be either difficult or easy to embolize. That depends a bit on how vascular they are. Generally speaking, the more vascular a tumor is, the easier it is to embolize. And this is why, for instance, hepatocellular carcinoma, which you all know is an arterially fed and usually very hypervascular tumor, is much more amenable to embolic treatment than, for instance, colorectal liver metastases, which are arterially supplied, but are much more hypovascular as compared to HCC. And we'll come to that later on a little bit. And again here, of course, coagulation is very important. Okay, to show you the essential difference between focal and diffuse disease, I have a slide here showing 3 diseased livers. Now this patient has one focal bleeding right here. You see this little dot of extravasated contrast here. So all you have to do here is occlude this branch here, and the patient will be stable and safe. So that's a very focal abnormality, very easy to treat. Now, in this patient who has had trauma to the right liver lobe, you can see that most of the branches of the right liver lobe show abnormalities here. You see all these diffuse contrast blushes. Now, this is much more difficult already, because what you have to do is close off all these branches here if you want to treat these patients. And if you close all these branches, you do have some chance of inducing ischemia. Also, look at the gallbladder here, the cystic artery. You don't want to include the cystic artery in your treatment. So you have to be quite selective and treat this one, that one, that one, that one, which is already much more difficult than this one. But then let's look at the third liver. This is a patient who has had a very large subcapsular hematoma that's ruptured into the peritoneal cavity. And what you see is all these small capsular vessels all bleeding, showing all these small extravasations. Now, basically, if you want to treat this, you're going to have to close all the branches supplying the liver. And you can imagine that the chance for developing ischemic complications in this case is many times higher than this case. And also the chances that you can do this more effectively than here are very low. So that's the principle of focal versus diffuse disease. So what then are the procedural steps during an archetypal embolic procedure? Well, there is, of course, pre-treatment imaging and planning, which we'll come to on the next slide. There is a stage where you gain vascular access and you try, with the help of angiography, to identify a lesion and think of an approach for the lesion. Then when you actually see the lesion, there is the choice to be made of the kind of embolic agent you want to use and the way and the location where you're going to employ it. And also, this is quite important because the use of embolic agents not only depends on the clotting stage of the patient, on the type of underlying disease, but also how selective you can get. If you cannot get very close to the disease, that may induce you to use another embolic agent than when you can get very close to the disease. And we may talk a little bit on follow-up, although I just said a few slides ago that probably in many cases follow-up is not required if the patient is in a good clinical condition. So what about treatment, imaging, and planning? Of course, there's many patients who do not require imaging before you go about and do an embolization procedure. And either an imaging procedure can be unnecessary, and I'll show you a few examples of that, or contrast can be a consideration. I guess pre-procedural CT or CTA and doing an angiogram right after this is always a trade-off between trying to save on contrast for the CT by not doing a CT, but then you may need more contrast during the angiography procedure, or trying to save the contrast during the angio procedure by doing a CT. There will be patients with poor renal functions in whom it's very, very likely that you're going to have to do an angio anyway. So in some patients, it's a good consideration to skip CT, save your 120 mLs or what have you on contrast, and use these for your angiogram. But this is a trade-off that you have to make every time. And of course, radiation, which is particularly an issue in young patients, but for instance, a very young patient who has a bleeding gastric or duodenal ulcer, it may be a very good consideration to skip the CT and go straight to angio, because the chances you're going to find something are very high, and the chances that the CT will bring you something that you don't know are quite low. So these are different considerations that may lead you to skip imaging. On the other hand, imaging can be very, very useful in many cases, and I think in many cases of embolization, the pre-procedural imaging is vital in either choosing your approach to the procedure or in choosing whether you are or not going to do the procedure. So one of the things that CT is helpful for is to deciding whether bleeding is arterial or venous in nature. There is some literature that says that a contrast blush can be either an arterial blush or a venous blush. So if you see something in the arterial phase, it's arterial. If you see it in the late phase, it's venous. This sometimes works, but very often you only see something, a scenario where you see bleeding in both the arterial and venous phase, or you see no bleeding at all. And if you see no bleeding at all in a patient who is unstable, for instance, a patient with a pelvic fracture after a motor vehicle accident, quite often it's safe to assume that this would be venous bleeding rather than arterial bleeding. And this may guide treatment because, for instance, a patient who had a pelvic trauma and doesn't show arterial bleeding on the CT angiogram may proceed to the OR and get a pelvic fixation device or something else. Instead, if the patient does show arterial extravasation on the CT scan, the patient may go to the angio suite and get an arterial embolization. So distinguishing between arterial and venous bleeding can, in some scenarios, and particularly in trauma scenarios, be very, very important. In other patients, it's very important to decide whether the patient is actually bleeding or not bleeding. Now, many patients who present with, for instance, GI bleeding or other types of bleeding do not show a continuous pattern of bleeding. But what they usually show is an intermittent pattern of bleeding. And sometimes the clinical signs, such as pulse acceleration or a decrease in blood pressure, are not helpful. So very often a CT is very interesting or very useful just to show that the patient is actually bleeding, and it's the correct moment to bring the patient down to angio and do the angiogram, because angiography relies very much on the finding that you actually see where the patient is bleeding. Particularly, for instance, a patient who has GI bleeding, you don't want to go about and close off a vessel that you haven't clearly seen bleeding, because GI embolization is associated with complications. So you only want to do the case when you know for sure that the patient is bleeding. So it very much guides treatment for these patients. And our hospital, I think many of the patients who undergo embolization from GI bleeding are first triaged by a CT to find out whether they're actually bleeding or not. In some other patients, CTA will be useful not so much for showing the bleeding, because clinically they have bleeding. For instance, a patient with cystic fibrosis who is experiencing hematemesis, well, you're pretty sure the patient's bleeding, so you don't have to do a CT scan to find out the patient is bleeding. And the patient also very, very often is intermittently bleeding. So in this patient, it's much more interesting to do your CT to find out where the bleeding is. Is it the right lobe, left lobe, upper lobe, lower lobe? And CT is very helpful for this and guided treatment. So in this kind of CTs, we're not looking for extravasation. We're basically looking for the location of the bleed, and that alone is enough to show us where we want to go. Then a vascular roadmap. Well, the same as, for instance, let's stick with the example of the bronchial artery embolization. A CT is a very good vascular roadmap for the anatomy of the bronchial artery anatomy. And as you may know, the bronchial artery anatomy is very variable from person to person. So it's really nice to know, before you go in and do the angio, to know where exactly which vessels are. So in this type of patients, the vascular rope map is very important, the location of the bleed is important, but finding the actual bleed on the CT is not at all important. So here's just a couple of examples of patients who are bleeding on CT. This is a trauma patient with a bleed here in the posterior aspect of the right liver lobe. Here's a patient who has a sizable hematoma around the kidney and shows some extravasation here coming from the ruptured cortex of the kidney. This patient has actually a duodenal bleed, and this patient here has extravasation in the pelvis in a pelvic fracture, where you see there's some diastasis of the symphysis pubis. Now the question always is the sensitivity of CT high enough to justify deciding on the basis of CT whether an angio is required or not? And I think this is an ongoing debate, but generally speaking, there is some evidence that says that the sensitivity of CT is about the same as angiography. There's some animal studies, actually a couple of animal studies that show that in GI bleeding, the sensitivity of CT is about the same, and in some cases, the sensitivity of CT could even be a little bit higher than of angiography. Now, it's difficult to compare because, as said before, patients may be bleeding intermittently, so during the scan they can be bleeding and they may not be bleeding when you're doing the angio. The contrast in the CT, of course, is administered via a vein, so it's more diluted when you actually do the scan than when you're doing an angiogram of a specific vessel. But in broad terms, I guess, yes, the sensitivity of CT and angio are the same. And if you look at some of the cases that have been shown for trauma embolization, if you guide your angio by CT, then series have shown that the accuracy of CT is quite high, in the order of 80% or more. So most of the time when the CT says there's bleeding, you'll actually find the bleed on angio, and most of the time when the CT is negative for bleeding, you will not find bleeding on the angio. Of course, I mean, a different policy can be dictated by clinical circumstances in some cases, but as a rule of thumb, I think it's safe to assume that the sensitivity of CT is about the same as angiography, so it can very well be used for doing triage. So who gets typically no imaging? I guess, which is a bit contradictory with my last slide, but upper GI bleeding. Suppose a patient is bleeding from a duodenal ulcer and the patient has been scoped by the GI doctor and says there's an ulcer in the duodenum. Well, there's not much that you need to know on the basis of a CT scan because you know where you're going to go. And there's only a limited number of vessels supplying duodenum, so you might as well go straight for imaging, for angiography. And the same goes for postpartum hemorrhage. Suppose a patient's bleeding after giving birth to a baby. You know exactly where the bleeding is from. It's going to be from the uterine arteries, and there's no point in doing imaging. You bring the patient down and do the angiography and embolization. Moreover, you don't even have to see the bleeding in a patient who has postpartum hemorrhage, because what you actually do is go about and embolize the uterine arteries anyway, even if you find no extravasation. For that particular purpose also, CT serves no purpose. So these are the typical kind of patients where you just can skip imaging and go straight for angio. Which ones do typically require imaging, preferably CTA? I guess most patients with lower GI bleeds, because quite often GI bleeds cannot be found by endoscopy, so you don't know where to go. And also the lower GI tract is a much larger area than the upper GI tract, because at the ligament of Treitz, that's where the lower GI tract starts, so it could be anywhere in small bowel or colon. And if you're doing a selective angio of all the vessels supplying the colon and short bowel and small bowel, it's a lot of work. And even, I guess if you look at some studies that suggest that CTA is probably even more sensitive than an angiogram for finding bleeding in the bowel. So in these patients, it would be a very good indication to go about and do your CTA first. The same goes for trauma bleeding. For reasons I've mentioned before, in trauma bleeding, it's very important to figure out whether a patient has arterial or venous bleeding, because this may guide treatment, and treatment for venous bleeding and arterial treatment can be completely different. Same goes for hemoptysis. I was just discussing, for instance, the example of a CF patient where we do not typically want to see the bleeding, but where we want to be guided by the vascular anatomy and the location of the bleed. And of course, in most elective cases, it's nice to have a CTA to be able to do sizing and planning of the procedure. But again, here, you have to have, in the back of your minds, contrast load and radiation issues. So let's now proceed to angio. We're actually going to start the procedure and talk a little bit about the vascular access and the lesion approach. 95 out of 100 embolizations can be done from the groin. So your typical normal puncture in the groin and the common femoral artery is usually standard approach to any kind of procedure. And when you actually have the catheter in the patient, you can start out by doing a sort of a global angiogram, for instance, of the whole aorta when you're looking for trauma. But if you're guided by a CT, it's quite often much better to go straight for a selective angio. So in patients, you have a CT, the CT is a little bit more contrast, but you can save on contrast by skipping the aortic runoffs and go straight for the selective series of the organ involved. For instance, this patient here, you see there's a midstream aortogram looking at the kidneys, the lumbar arteries, and I see some faint opacification here of some bleeding from small side branches of the internal iliacs. But if you would have known on the base of CT the patient was bleeding from the internal iliacs, you might as well have gone up and over the bifurcation, straight into the internal iliac, do your angiogram, and see exactly from which vessel the bleeding is coming. And this saves you time, it saves you contrast, it saves you radiation. So in this kind of situation, the trade-off between doing CT, increasing contrast, and radiation load works out really well. What then is the materials you use? Well, it's mandatory to use a sheath in every patient. The reason is that when you're doing a procedure, you very often have to change catheters and wires, so you always have to have a sheath in place. And particularly when you have your catheter quite close to the bleed, it's a shame if you have to take it out again over a wire to change for a sheath. So put in the sheath first, and about 90 out of 100 embolizations can be done using a regular 5 French diagnostic sheath. So you start out with a 5 French sheath, and then you take it from there. Usually you start out with regular diagnostic catheters, which are usually 4 or 5 French in diameters, and quite often normal wires like stiff wires or hydrophilic glide wires to get more selective. Now, there's different size requirements. In some patients, you have small vessels. You need to negotiate your way. They're going with microcatheters that go coaxially through normal catheters. And in some patients, it's easy to get to the bleeding vessel. You can just use a 5 French catheter. And here, it's very much a matter of flexibility versus stability. And I'll show you in the next slide what I mean with that. You see a patient here, and we see here a patient is bleeding from the gastroduodenal artery, probably from a duodenal ulcer. And you can see how the regular 5 French Cobra catheter has been put into the celiac axis, goes into the hepatic artery, and then sticks its nose right here into the gastroduodenal artery. Now, this is a very stable position because it's quite a rigid catheter. So if you have it down here, that's nice. You can leave it here, push out your embolization coils, and do the procedure. So this is a very easy and stable position. But let's look at this situation here. This is a patient who has a bleeding from the spleen after a trauma. Here's the big subcapsular hematoma. Here you see the contrast extravasation. And now what we need to do is get into the celiac axis here and then work our way all the way like this and all these bends to treat the bleed. Now you can imagine that a very stable and rigid catheter won't make it to there. So there we have to go for something that's a more flexible solution. And the rigid, stable catheter, which is nice to use, doesn't get very far. And here we use a coaxial microcatheter that you can work all the way up to the bleed here, deploy the coils here, and only take out the upper portion of the spleen when you're embolizing. Now, it would be easier and quicker to use this catheter, but again here, sometimes there's a trade-off between rigidity and stability and flexibility. So once we get to a bleed, what types of embolics can we use? Well, I guess in very broad terms, this is the different kinds: coils and plugs, particulate agents, and liquid agents. As in many things in interventional radiology, I guess diagnostic radiology, and other things in life, the 80-20% rule very much applies here. So if you have a shelf full of embolization materials, you can probably do the vast majority, 80% of your procedures or more, with only 20% of materials. So you have some standard basic size of coils and some standard basic types of particles. You have some standard sheets of gel foam. And with only these few types of materials, you could do the vast majority of cases. And particularly all your GI bleeds, lung bleeds, trauma bleeds will probably all be treated by just having a small variation in sizes of coils, some particulate agents, and a few pledges of gel foam. And for all those very difficult and special procedures, you need those other 80% of equipment that you have on the shelf. So if you only do a limited number of procedures, it's very hard to figure out what kind of stock you actually need to have on the shelf to do all the procedures and not end up in a situation where you don't have the right materials. So the first type is coils and plugs. There's different types of coils. There's so-called detachable coils, and there's non-detachable coils, and there's plugs, which is basically a variation on the same theme. The regular best-known coil is this type of coil, where it's a straight metallic wire with some Dacron side branches. I'll show you some blow-ups in the next slide, that you push through the catheter, you push it out, it falls out into the vessel, and that's where it stays. So it's the easiest and most used type of coil. And for most of peripheral applications, so non-neuro applications, we still use this type of coils in 9 out of 10 times, and they work really well and easy. So here are some different kinds of coils. On the left-hand side, you see the regular coils that we use in most peripheral situations, and this is the type of coils that are used for neuro. Now, I'm not a neurointerventional radiologist, so I'll just say a limited number of words on neuro, and this is the type I use most. But these are essentially different. As you look at the coil here, it's a short metallic wire that curls up in a preformed or pre-assessed dimension, and it has these Dacron side fibers which induce irritation of the bowel wall, and these are a very nice platform for coagulation, so a platform for clots to form on. So what you basically do is you put this into a vessel, and it doesn't really obstruct the vessel because there's a lot of lumen side around it and in it, but what it does is promotes clot formation. So basically it's a platform of clot formation rather than actually occluding the vessel itself. Now the situation in the type of neurocoil is completely different here. You'll see how this virtual aneurysm here is completely filled up with coil. And you can also see there's no side fibers coming from the coil. So this coil will produce almost no clotting. So what you basically do in neurocoiling is just filling the whole aneurysm with the coil. So basically just filling it up with material so there's no blood inside. So the treatment is essentially different. In neurointerventional, it's just filling up the whole aneurysm. In peripheral application, it's basically providing a platform for clot formation, which also implies that if you want to use coils, the patient has to have a decent coagulation station. If the patient has very poor clotting, coils will not work, and the blood will just flow through the coils and not clot. Again, here you can see the difference. It's short. There's just a couple of windings here, and it doesn't fill up the lumen of the vessel. It's the threads on the side that promote the clot formation. Here, it's a lot of wire. So this is meters of wire, and this is just a couple of centimeters of wire. So what do the coils do? Well, they cause proximal vascular occlusion because exactly where you deploy them, that's where they stay. So you have to catheter all the way out to where you actually want to deploy the coil. And as you cannot get out very much into the periphery of a vessel, I mean, not much less than a millimeter, in very many cases, what you're doing is proximal vascular occlusion. So it promotes clot formation there. For pushing out coils, a certain stability of your catheter position is required. So before you actually start pushing out coils, what you always have to do is confirm a stable position with your catheter. So you put out a guide wire a little bit, see if it stays in place, and if it stays in place, and when you push out the guide wire for a few centimeters or so, you may assume that it'll stay in place when you push out the coils. In coils, there are a wide range of sizes, and as a general rule of thumb, you should oversize the coils a little bit. For instance, if you're coiling a 5 millimeter artery, it's probably best to start out with a 6 or 7 millimeter coil. Once you have it in place and it stays there, you may choose other sizes to fill up the space between your catheter and the first coil with coils, because then the first coil serves as sort of a scaffold that you can build your consecutive coils on. But as a rule of thumb, start a little large. When you're doing venous embolization, start even larger. For instance, a 5 millimeter vein, you should probably start with an 8 or 9 coil and then put smaller coils in. And they are most commonly used for instance, trauma bleeding and GI bleeding. So this is what happens when you insert a coil. For instance, this is a schematic drawing of a vessel and a bleed here. When this is an end artery, so there's not much other branches coming off or either going in, and you get your catheter out all the way to here. You occlude the vessel here with a coil, and you have a good occlusion of the bleed. On the other hand, if this artery functions as sort of a transportation artery or has a lot of collateral supply, what will happen is this. You'll see the bleed here. You can get your catheter all the way out to here. Here's the bleed again. You occlude this little portion of vessel, but all these collaterals will supply the bleed, and the bleeding will go on. So in this kind of scenario, you have to be very close to the bleeding in order for the collaterals not to be filling the bleeding anymore. So here you have to get much further out, use a microcath, and be very close to the bleed. And in some situations, this is not possible, and you have to choose another embolic agent, for instance, an embolic agent that flows downstream. Other situation is here, where you have an aneurysm. Well, if you have an aneurysm, what we usually use is something that we call the front and back door principle, because if you occlude the aneurysm from this side, there'll be a retrograde filling from the other side via collateral. So what you have to do is close the front door and the back door. Of course, when you're coming from here, the first thing to do is close the back door and then the front door. And I'll show you an example of this later on. There's also situations, and these are rare situations, where you cannot get close to the bleed, where there is collateral filling, but still proximal coiling can be helpful. And this can, for instance, be used in the case of a trauma to the spleen, because what you can induce sometimes is here, occluding the vessel. This will lower the perfusion pressure in the spleen, the bleeding will stop, and there still will be some collateral supply. And there will be enough collateral supply to prevent ischemia of the spleen, but it will stop the bleeding. So the blood pressure goes down in the spleen, the perfusion pressure goes down, there is collateral filling, but it's just enough to get the bleeding to stop. But you cannot always rely on this, and it doesn't work in every organ. So this is the different ways or approaches you can have to coil embolization. Simple example here, a bleed here. This is the proper hepatic artery, the gastroduodenal bleed here. You can get all the way to the bleed. You can get beyond the bleed. So here you close the back door, here you close the front door, and you're using only 2 coils. You've solved the problem. In other situations, you need some more coils because there's a very small feeding vessel here, too small to get into. So what you do then is start here and work your way back to up to here. So again, here you've closed the back door and the front door of the bleed. As a rule of thumb, you want to be as selective as you can. So here, this is a splenic rupture and a trauma. We see the extravasation of the spleen here and the upper pole artery here. When we can get our microcath out all the way here, and we can, you see that it's actually coming out of the vessel here, and you see free flow of contrast into the peritoneal cavity. You deploy coils here, and you've done selective embolization. But in the situation we have here, there's an aneurysm coming from the splenic artery. What we again have to do here is occlude the whole artery, but keep in mind that this is a transportation artery, and it has a lot of collateral supply. So what do? We pass the bleed here, put some coils here, put some here. So we close the back door, close the front door, and use the fact that there is some collateral supply, and here see some faint filling of the distal splenic artery. So sometimes the collaterals are in our disadvantage, but sometimes we can use them for our advantage, as shown here. Now, this is a situation where there's many focal bleeds. So basically, we're talking about a diffuse disease case here. And it's very difficult to occlude this because if we're going to occlude all these vessels here, we're actually going to make the complete spleen completely necrotic. So what we do is deploy something here, a device, actually not a coil, but a plug, which I'll show you later on. And you see that posterior to the coil, there is some filling, but the perfusion pressure is much lower than before, and you see hardly any parenchymal filling, so the bleeding stops on the basis of a lowered perfusion pressure without actually making the spleen ischemic. So these are some examples of these schematic draws I've shown you before. One problem with coils is that if you put in one coil too many, it can stick out into the wrong vessel. You can occlude a so-called non-target vessel. Here we wanted to occlude the gastroduodenal artery, but actually the last coil is sticking out into the hepatic artery here. And we do not want to compromise the vascularization of the liver. So sometimes you can get out a snare, catch the coil, and push it out, and then you end up with a result like this. So you pull out the additional coil. Sometimes you don't succeed, so you have to be very careful. Basically, there's only 2 difficult coils. It's the first one you place and the last one you place. Here, just one short example of the way coiling is used in a neuroaneurysm. As you can see here, is a bleeding of the an aneurysm of the medial cerebral artery, and you see there's a lot of coil going in there. And here you see how the coil is stuck to the catheter, and you can push it all the way up, all the way in, see how it fills up, see if it stays there, and then detaches, and then you leave it there. So you can see there's much more of a coil mass. There's actually a whole bulk of coil sitting in there, and you're actually filling the whole aneurysm rather than just promoting hemostasis on the basis of a platform for hemostasis. I already mentioned a few words on plugs. This is what the plugs look like. You can detach them by screwing on the device. They are easy to work, but sometimes they require bigger deployment catheters than coils, but they basically serve the same function. You may need fewer of these than you need coils. On the other hand, they're more expensive than coils, so I guess the trade-off money-wise varies from institution to institution. And I showed you this image here where we're closing off a proximal splenic artery, and here you see that the basket is deployed. So same as coils, it induces proximal vascular occlusion. It also works on the basis of clot formation because you see it's just a basket and clot has to form within the basket. So sometimes it takes up to 5 or 10 minutes before actually the clot forms. So you have to wait a little bit after deploying it before you do a check angiogram. A stable catheter position is required, but the good thing about these plugs is that they are repositionable. So if you have positioned it and you haven't detached it yet and you don't like the position, you can pull it back and try it again. A bigger size guiding catheter is often required, and there's a limited number of sizes. These plugs need significant oversizing. I said that coils need to be oversized by 10 or 20% or something like that, but usually plugs need to be oversized by at least 30 or preferably 50%. So you need a quite big plug for a not so big vessel, and they're commonly used for internal iliac artery occlusion prior to EVAR placement. Then we come to particles. Particles are basically just small bits of piece of different materials that you can inject, and they work by means of flow guidance. So you inject them and they just go with the flow until they get lodged in the vessel. The most commonly used one is called PVA, polyvinyl alcohol. It's been around for ages and we're still using it for many applications. Nowadays on the market there's some new types of particles called calibrated microspheres that are all the same sizes. Theoretically have some advantages, but in everyday practice basically, there isn't much difference between PVA and calibrated microspheres. Drug-eluting beads are basically also calibrated microspheres that you can load up with a pharmacological agent. So, for instance, you can use these for chemoembolization, so you can load them up with chemotherapy. And this is widely used for treatment of hepatocellular carcinoma and more rarely used for treating liver metastases. Gel foam comes in sheath, and I'll show you a picture later on, but basically the way you use gel foam, it is actually also a particle in the way you use it because it works by means of flow guidance. So PVA is the archetypal standard agent. It comes in a wide range of sizes, somewhere between 100 and 1,000 micrometers. It says 100 to 100, but it's 100 to 1,000. So it's 1/10 of a millimeter. What happens in practice are these, because this is an image of a microscope picture of a vessel with the black stuff, which is PVA, in it, and you can see how irregular the shape is. And what these things tend to do is clot and stick to each other. So basically, when you inject something that is 1/10 of a millimeter, they tend to clump together and occlude vessels that are slightly larger than 1/10 of a millimeter. So if you take that into account and you use a 1/10 of a millimeter PVA particles, they will probably occlude vessels and get stuck in a vessel somewhere around the size of 200 or 300 micron. So they're basically in their use a little bit bigger than the size they come in. And this doesn't work that way from calibrated microspheres, because if you're injecting microspheres that are calibrated and they're 100, they're exactly 100 and they don't stick to each other. So you include smaller vessels. They're flow dependent, so wherever you leave your catheter injecting, that's where they start and they just flow downstream until they stop. So that means that you usually get more peripheral embolization than coils. So they're used particularly for indications where you want to obtain more distal occlusion. You have to use very careful injection because there's the risk of reflux. And generally speaking, particles are more difficult and hazardous to use than coils. They're quite commonly used for hemoptysis and nowadays also quite often for uterine artery fibroid embolization, uterine fibroid embolization. Here's an example, bronchial artery. Here's a 5 French catheter. You want to occlude all these small pathologic vessels here and here and here. And what happens is if you put a coil here or put coils here, you're going to have a lot of collateral flow and the bleeding will not stop. So you want to be much more peripheral and downstream. You put in a microcath up until here, and then you start injecting the particles and they go everywhere. So they occlude the vessel here and here and here and here. So you occlude this whole vascular bed by injecting microparticles from one location. So it's easier and quicker than coils in this scenario, and it works better. And this is what you have after the procedure. You see there's almost complete stasis, and all the side branches are gone. Another situation here, another bronchial artery bleed. Something that you have to take into account is if you inject the particles, they will go everywhere. So they will not automatically choose the bronchial artery, but they will also go into the intercostal artery. So what you really want to reach is a result where you put your microcath beyond the side branches. For instance, here, we put it beyond the side branch, so the intercostal artery here. We're injecting here, and then all these vessels get debranched by the PVA particles. And this is a situation after the procedure where you see there's complete stasis. Same goes for uterine fibroid here. Here is the uterine artery which supplies the big fibroid, and you inject the particles and you go on until there's almost stasis. Just a few words on drug-eluting beads, which are basically particles that are loaded up with some type of chemotherapeutic agent. So you load them up, the pharmacist in your hospital will do it. It obtains peripheral embolization. You have to use very careful injection because if there's reflux to other vessels, this may lead to severe problems. Of course, most of the time we do it in the liver, and in the liver it's quite safe because if you embolize just in a small branch of liver, usually there's not much clinical sequelae. And it's commonly used for hepatocellular carcinoma and less frequently for other indications. Here's one example, a very hypervascular HCC here sitting in the sixth segment of the right liver lobe. You see it's very hypervascular. You can imagine what it would look like on the CT or MR with contrast. You get your catheter out as far as you can, as close to the tumor as you can, and then you start injecting the drug-eluting beads, and you fill up the whole lesion with these drug-eluting beads, and the beads will stay there, so they'll promote ischemia of the lesion, and at the same time, the chemotherapeutic agent will slowly dissolve from the beads into the tumor and do their work there. It's been a matter of debate whether the efficacy of this procedure is mainly caused by embolization or the chemotherapy, and it isn't really known, although probably the most part is done by inducing ischemia by the embolization itself. Here's an example where you can combine different kinds of embolic agents. Here you want to embolize the whole portal vein. This is the portal vein with all the side branches. You can first occlude them all with PVA particles, inject them here until there's no more side branches, and then put in coils. And the end result is a combination of peripheral and central occlusion. Gel foam is basically a resorbable material, and that's why we use it in some scenarios. For instance, patients who have trauma or postpartum hemorrhage, where you want to treat something focal, that's for a short period of time, and when the patient is stable, the gel foam can dissolve and the vessel may open up again, which is fine because you're not treating a chronic disease in these patients. It's also flow dependent. It's more peripheral embolization than coils, and how peripheral it gets depends basically on how small you cut the pieces. So this is a sheet of gel foam. You can cut them into pieces yourself and decide how peripheral you want to be. You can also cut them into the shape of a torpedo, and you can imagine that then you're going to do basically a proximal occlusion. So there's a wide range of signs, which is basically because you can customize them yourself. A few examples here is a patient who has a postpartum hemorrhage. You see pregnant uterine artery, which is very hypertrophic, and all these hyperemic branches. And you can treat all this with a few shots of gel foam. And the uterine artery will, after the patient stabilizes, recanalize. And this is potentially helpful for future pregnancies. Same goes for this trauma patient here. A lot of small blushes. You want to be quick because the patient's unstable, so you get your catheter out here to inject just a few pledges of gel foam and the whole vessel is closed off, so it's quick and dirty, as you might say. This is a patient who is in a very poor hemodynamic situation. You can see there's an external fixation device on the pelvis. Here's bleeding from both internal iliac arteries, and the best thing you can do here is not fiddle around, but just inject a little gel foam in here and here, which will only take a few minutes, and if the patient stabilizes, hopefully the internal iliacs will recanalize. Liquid agents I'll only talk about just for a few minutes because they're difficult to use, they're hazardous to use, and they basically shouldn't be used by people who are functioning at a basic or intermediate level. These are expert materials, and even in expert hands, complications do occur. They're liquid, and their viscosity is variable because you can actually, by dissolving them, you can create your own viscosity. So if you want the liquid agent to go more distally, you change the viscosity so it becomes less viscous. It'll go further. If you want it to form a clot very close to your catheter, you make it more viscous so it doesn't get very far in a vessel. It's basically flow dependent, such as the other same as particles. It's used for peripheral embolization and should also inject very peripherally. So if you want to inject it, and it's usually used for AVMs or AVFs, you have to be very close to the abnormality if you want to use it, because it immediately starts clotting exactly where it leaves the tip of the catheter. So if you do it somewhere proximal, as you would do sometimes in some other arteries with PVA, it'll start clotting there instead of way downstream. Here's an example of a big AV malformation in the shoulder that's treated with glue. With a result like this, it's radiopaque, so this is the angio picture, and this is no flow. This is the radiopaque embolic agent. And the same goes for the situation here. This is a meningeal artery here. This is abnormality that needs to be treated. You get your catheter all the way out there, very, very close to the abnormality. Then this glue type of stuff, which is called onyx, comes out, and you exclude it here, and you see how all this stuff is radiopaque and sitting exactly where you want it. So again, very difficult to use. What about complications? Well, there's complications. There's puncture site complications, systemic complications, embolization-related complications. And I guess the puncture site complication and the systemic complication are the same as any kind of angio. So thrombosis, hematoma, hemorrhage, dissection, contrast-induced nephropathy, of course, allergic reactions, although nowadays very rare, and if you use a lot of contrast, congestive heart failure. But more interesting in this setting is embolization-specific complications, such as non-target organ ischemia, which means that you induce ischemia to an organ that isn't in the aim of treating. And this may cause clinical complaints in some patients. For instance, when you're doing a splenic case or a renal case, it is the expected result of a procedure. So some ischemia and some infarction is basically the result of a procedure rather than a complication of a procedure. Many times types of embolization will have a so-called post-embolization syndrome, which typically occurs after chemoembolization, but also some other types. And the problem is, and this is where we need imagers, is to differentiate post-embolization syndrome, which consists of fever, nausea, general malaise, from infection. And this is sometimes difficult. I only have one example here of a patient in whom we treated a celiac axis aneurysm here. This is the aneurysm. Here putting in all these coils, and the patient comes to the emergency department a couple of days later, and there's an ultrasound of the spleen which shows a little few air bubbles, and the operator who's done the ultrasound says, well, this is air bubbles, which is normal after procedure. It's a post-embolization syndrome, but no infection. And then the patient comes back another week later, now has higher fever, leukocytosis, general malaise, and what you see when you do the CT scan is a completely infarcted spleen, which has become necrotic, and eventually it turned out to be an abscess, and we had to drain this, and eventually the spleen came out. So, and although this case looks easy in everyday clinical practice, it's very often very difficult to differentiate the two. I think the amount of leukocytosis, the duration of the symptoms may help to differentiate, but imaging, particularly in the first couple of days after the procedure, do not really help to differentiate infection or abscess from a post-embolization syndrome. So what are the results and complications? Very difficult to say. There's very straightforward scenarios in patients who are acutely bleeding, such as postpartum hemorrhage, GI hemorrhage, bronchial artery hemorrhage, trauma hemorrhage. Results there are usually very good because you're dealing with most often not diffuse but focal disease, and the technical success but also the clinical success in these patients is usually in most series over 80 and many series over 90%. It's much more difficult in other types of procedures, for instance, uterine fibroids, AVM, STACE. The endpoints, the clinical endpoints are much more difficult. In uterine fibroids, the endpoint will be diminished blood loss on the long term, fewer mechanical complaints. In AVMs, it would be cosmetic changes, and for instance, STACE, it would be either progression-free survival or time to progression, overall survival, which is much more difficult to assess. So what then are the take-home messages from this talk? I hope I've explained that the choice of techniques and devices depends very heavily on the vascular territory that you would need to be treating and the underlying or the type of underlying disease. I guess the 80 and 20% rule that we use for many things in life also applies to embolic agents. You can do most of the procedures that you need on a routine day basis with only 20% of your materials, and for those rare cases you need these other 80% of rare embolic agents. The kind of imaging workup or the need for imaging workup depends very much on the type of embolization. The results and complications are very dependent on the vasculatory, as I've outlined before, and also on the underlying disease. So the outcome also depends on the aim of the embolization. The aim of the embolization, which I've spelled out in a very technical way, is basically the clinical situation of the patient. So that leaves us with only 2 minutes. So as a moderator, I'm going to ask you to get me some questions. Anyone from the audience? It's difficult for the moderator to come up with questions in this case. Okay. If no, I thank you very much for your attention. And I guess it's probably one of the last lectures, so I wish you all a safe trip home.